more than that. They can be triggered by things like physical pressure, temperature changes, infections, hormones, and even signals from your own body when cells are stressed or irritated. So they're not just reacting to the outside world, they're also responding to what's happening internally. And when mast cells are activated, they release a wide range of chemicals like histamine and other inflammatory molecules. These signals act locally in the tissue. They can change blood flow, call in other immune cells, and importantly, they can directly activate and sensitize nearby nerves. And that last part is key. Mast cells sit right next to nerves. So when they release those signals, they can make those nerves more sensitive, which is one of the ways this can translate into symptoms like pain, discomfort, or that heightened sensitivity that we refer to as visceral hypersensitivity that we see in IBS. And under normal conditions, this system is actually very helpful. Mast cells play an important role in protecting us, helping with healing and coordinating the immune response when necessary. But problems arise when the system is a bit too oversensitive or overreactive. And when that happens, the same system that's meant to protect us can start to drive ongoing symptoms, especially in conditions like IBS, where the threshold for activation appears to be much lower. So now if we take everything that we've talked about, the idea that stress gets translated into gut symptoms through this nerve mast cell connection, we can actually test that directly in people. And that's exactly what another study did. Researchers took patients with IBS and healthy controls and used a specialized catheter placed within the small intestine, measuring what was happening in real time, including mast cell activation, how leaky the gut lining was, and how much fluid the gut was secreting. They first administered corticotropin releasing factor through an IV, essentially recreating the stress in a very controlled manner. At the whole body level, both groups, those with IBS and those without, reacted the same. Stress hormones increased, the heart rate went up, and patients felt more stress. So the brain, the hormonal response to stress was normal. But when they looked at the gut, that's where everything changed. Even before the stress signal, patients with IBS had more mast cells. And when CRF was given, mast cell activation increased in both groups, but was much more profound in IBS. This is accompanied by the gut lining become more permeable or leaky, more fluid being secreted to the intestines, and importantly, only those with IBS experience increased abdominal pain, and that pain closely tracked with the aforementioned changes. So this is, again, another study that shows that the issue in IBS is not the stress signal itself, but how the gut responds to it, with the nerve mast cell barrier system becoming a little bit more reactive. So let's build a stronger case for the role of mast cells in IBS by looking more closely at some more data. In one study, researchers took small tissue samples from the colon of patients with IBS and compared them with healthy individuals using special staining to identify mast cells. What they found was that patients with IBS had nearly double the amount of mast cells in the lining of the gut compared to controls. And this wasn't limited to one subtype. It was seen across IBS as a whole. So in IBS, the baseline environment is different, and there's simply more mast cells sitting in the gut lining, which means that the system in and of itself is primed to be more reactive and more sensitive to triggers. Now we take the next step, because not just that there are more mast cells in those with IBS, it's what those mast cells are actually doing. In that same study, researchers looked at these mast cells under very high magnification to see whether they were releasing their contents. What they found was a significant increase. About 150% more mast cells were actively degranulating, meaning they were turned on and releasing more inflammatory signals. Then they looked at this from a functional perspective. They took those tissue samples, kept them alive outside of the body, and again, the differences were clear. Levels of tryptase, a key marker in mast cell activation, were nearly 4 times higher in IBS, and histamine levels were about doubled. So when you put this together, it's no longer just about having more mast cells. It's that these cells are more active and releasing more of the chemicals that can affect nearby nerves, the gut lining, and how the gut functions. So now we take one final step, because it's not just that the mast cells are increased and more active, it's also where they're located. In that same study, researchers looked at how close mast cells were to the nerves within the gut. What they found was a major difference. There were over twice as many mast cells sitting extremely close to nerve fibers in those with IBS compared to healthy individuals. In many cases, these cells weren't just nearby, they were essentially touching the nerves. And that proximity seemed to really matter. The closer these mast cells were to nerves, the worse the patient's symptoms were, especially when it came down to abdominal pain and how frequently it occurred. So when putting this all together, it's not just that there are more mast cells or that they're more active, it's that they're positioned exactly where they can have the biggest impact, sitting right next to nerves that allows these chemicals and their mediators to directly influence how those nerves fire. making the gut more sensitive and helping drive pain and discomfort that we see in irritable bowel syndrome. So at this point, we built a pretty strong case that mast cells are playing an important role in IBS. But it leads to the next question: why are they so active in the first place? There's two ways to think about this. The first is that something is inherently wrong with the mast cells themselves. In rare conditions like systemic mastocytosis, which is an oncologic or cancerous process, these mast cells are inherently abnormal, mutated, and prone to activating too easily. But that is not likely what we're seeing in MCAS or IBS. The more likely explanation is that mast cells themselves are normal, but the environment they're in is consistently triggering them. Mast cells are designed to act like sensors. They're always scanning the surroundings, responding to signals from the gut lining and the nervous system. So if that environment is off, whether it's due to changes in the gut barrier, ongoing stress signals from the nervous system, the mast cells interpret that as a problem and continue to activate. And that shifts how we think about IBS. Instead of asking what's wrong with the mast cells, we start asking, what are the mast cells reacting to? So if the question becomes, what are they reacting to? The answer in many cases is the environment around them. One of the key ideas here is something called gut or intestinal barriers. The lining of the gut is supposed to act like a filter, letting nutrients in while keeping harmful things out. But when that barrier becomes sensitive or disruptive, more substances like food particles, bacteria, irritants can cross into the tissue. And at the same time, mast cells are sitting right at this interface, seeing all of these noise. They're constantly sampling what's coming through, and they're also listening to signals from the nearby nerves. So when things are getting through the barrier and the signals are being more signals are being sent, the mast cells interpret this as a reason to activate. And when you layer on modern factors like changes in the microbiome, antibiotic use, processed foods, environmental exposures, infections, and ongoing stress, there are growing concerns that these may be impacting the integrity of our gut barriers. And while this is still a very much active area of research, the idea is that these factors could make the barrier more vulnerable, allowing more signals and irritants to reach the immune system. So, building on that idea, we start to look at what may be shaping the intestinal environment in the first place. One idea that's getting a lot of attention is everyday environmental exposures like detergents, cleaning products, fragrances, and pollutants. These things that we're exposed to constantly, often at low levels. There's growing evidence that some of these exposures can affect how well our epithelial barriers function. And in experimental settings, certain compounds have been shown to loosen the connections between cells in the lining, making it easier for substances to pass through. And while this research is still very much evolving, it raised an important possibility that repeated low-level exposures over time may gradually make the barrier more vulnerable. And when that happens, it changes the signals being sent to the gut. The lining, the nerves, the immune system are all exposed to more input, which can increase signaling between them and make the system more reactive overall. Over time, especially with repeated hits like infections or inflammation, this can shift the system into a state where it's more easily triggered and slower to settle. And clinically, I see this all the time. Patients move to different countries where food is handled, grown and processed differently, where there are different environmental exposures, and they feel so much better or so much worse. Crohn's disease is Crohn's disease in Chicago versus Australia. Lymphoma or cancer is the same in Tahiti versus Rhode Island, but MCAS behaves differently in all different environments. I've seen people's symptoms completely abate while traveling to a wedding in Ecuador. It's pretty fascinating. And so the key takeaway here is that changes in the environment, especially at the level of the barrier, may play an important role of shaping how reactive the system becomes over time. So let's bring this back into the clinic. And while we often define IBS by gastrointestinal symptoms, it's important to recognize that mast cells are not just located within the gut. They're distributed throughout the body, especially at the barrier surfaces like the skin, airways, and genitourinary tract. And because of that, when mast cells actively degranulate, it doesn't just stay within one organ system. And clinically, that's often what we see. Certainly not in all. Some people have just GI symptoms or more allergy symptoms, but a meaningful subset also report symptoms kind of throughout all systems throughout the body. Brain fog, fatigue, headaches, flushing, itching, palpitations, dizziness, pelvic bladder discomfort, it runs the gamut. These symptoms can seem unrelated at first, but biologically, they can all be connected to the same mast cell-driven process. And when you start looking beyond IBS, a certain pattern emerges. Other painful, so-called idiopathic conditions like fibromyalgia, interstitial cystitis, vestibular migraines often show improvements when mast cell pathways are targeted, suggesting that these conditions may share a common underlying driver. If we start to think about IBS, and in some of these patients, a broader mast cell-driven picture, a system that's being continuously triggered, it shifts how we approach treatment. When I'm working with patients who have this type of physiology, I'm not just thinking about medications, I'm thinking about the entire environment in totality. A big part of what we do in clinic is identify and reduce everyday exposures that may be quietly keeping the system activated. And for many people, those triggers aren't necessarily obvious. Things like fragrances, cleaning products, or air quality, or even new materials in the home releasing chemicals in the air, like a Glade plugin. So, one of the first steps is helping create a more stable baseline. And that means maybe transitioning to more fragrance-free products, improving air quality, and being more intentional about what you bring into your home. We'll also talk about simple and meaningful adjustments like ventilation, reducing buildup of irritants, and being mindful of exposures in public places. We also look at how your body's interacting with the surroundings, things like hot showers, how does that work with your body? Water quality and exposures all can play a role. So we'll often make these small adjustments using gentler products and reducing unnecessary irritation. Importantly, we also want to keep this very practical. The goal is not to make your world smaller, it's to reduce the overall load on your system in a thoughtful way. When we do this, it often creates a more stable foundation, and that's when other treatments can work more effectively. And once we start to stabilize the external environment, the next layer that we think about is what we're putting into our body. Because food is another major way the gut can interact with its surroundings. And there's two dietary patterns I tend to discuss most in this situation. One is a gluten-free diet, and the other one is a low histamine diet. Starting with gluten, some patients experience whole body symptoms after eating gluten, even when celiac testing is completely normal. The second is a low histamine approach, which is about really about lowering foods that are high in histamine, obviously, and those can trigger its release. Practically, that means cutting back on things like aged fermented foods, as well as being mindful of certain fruits and vegetables like tomatoes, spinach, avocados, eggplant, strawberries, bananas, and citrus. I also emphasize freshness, especially with cooking fish, and minimizing leftovers by cooking fresh and freezing leftovers when needed. Because the longer food accumulates in your refrigerator, the higher histamine content it typically has. Now, importantly, these approaches don't work for everybody. One may help, and the other may not work at all. Um, so these trials are they're just trials. They're not permanent prescriptions. And while we don't have strong clinical data supporting these diets, specifically for mast cell related symptoms, they can be helpful for some patients. And the goal is to test thoughtfully, learn from the body's response, and keep the approach flexible without creating unnecessary restriction or impacting nutrition and quality of life. And most importantly, I generally recommend working with a dietitian to do this in a structured, responsible way. Couple other things is that some people benefit from a low FODMAP diet as well. I tend to think of the gluten-free diet and the low histamine diet helping with more systemic symptoms, brain fog, migraines, mood, joint pains, etc. But if some people have symptoms isolated to the intestines, bloating, diarrhea, constipation, that's where a low FODMAP diet can help as well. It is just a little bit more restrictive. So if I do the FODMAP diet, I typically limit it to the simple FODMAP diet, which is eliminating the two most common triggers, which is fructans and galacto-oligosaccharides. And and the most important thing here is that some people in this space are already so incredibly limited in terms of what they can eat. So if that is the situation and the case, now is not the right time to start eliminating foods because all that can do is create a lot more food anxiety, which won't really help anything. So another layer here is thinking about the nervous system because everything that we've talked about from corticotropin releasing factor to mast cells and barrier function is heavily influenced by how the body perceives stress. And this is where therapies like gut-directed cognitive behavioral therapy, hypnotherapy, and brain retraining programs like Primal Trust or DNRS come into play. They're often thought as purely psychological, but that really misses what's happening biologically. A better way to think about them is that they're targeting the same stress pathways we discussed earlier, particularly CRF. By lowering that stress signal, they help calm the nervous system, which can reduce downstream effects like mast cell activation, barrier disruption, and pain amplification. Now, jumping into pharmacotherapy, once we understand the mechanism, the treatment strategy becomes a lot more intuitive. So if mast cells are playing a central role, then one of the most logical first steps is to target what they're releasing. And one of the key players here is histamine. Histamine works throughout the body in different ways, including in the gut and the nerves themselves. H1 receptors are particularly important when it comes to pain. They sit on sensory nerves and can amplify how strongly symptoms are felt, or signals are felt, I'm sorry, contributing to that visceral hypersensitivity that we talked about. H2 receptors play a more supportive role, especially things like acid secretion, vascular effects, and sometimes leading to symptoms. And there's also receptors in the cardiovascular system leading to symptoms like palpitations when they are agonized. And we actually do have some clinical data to support using antihistamines in this role in IBS. And in one randomized trial, using H1 blockers to see if using an H1 blocker, I'm sorry, led to meaningful improvements in overall IBS symptoms and abdominal pain compared to placebo. In another study looking at functional abdominal pain, which is a different subset of a disorder of the brain-gut interaction where people have a lot of pain in their upper abdomen without necessarily changes in bowel habits. A majority of patients who were treated with an antihistamine had a significant improvement, far more than those on placebo. So histamine actively seems to contribute to symptoms. And by targeting that pathway, we can sometimes, in the right person, directly reduce nerve sensitivity and improve how people experience their symptoms. Unfortunately, histamine is only one of the 1,300 chemical mediators and major outputs that mast cells release. And that's where leukotrienes come into the picture as well. Mast cells also produce leukotrienes, which affect many of the same systems that we've been talking about. In the gut, they can increase smooth muscle contraction, which can drive cramping and urgency. They can increase vascular permeability, which contributes to swelling and diarrhea. And they also can amplify inflammatory signaling pathways, which can further feed into visceral hypersensitivity. And we have some preclinical data to support this. In an experimental IBS model, blocking leukotrienes with Singulair, otherwise known as montelukast, led to reduced visceral hypersensitivity. It also, interestingly, reduced stool frequency and dampened inflammatory signaling. So mast cells are not just a histamine story, unfortunately, they're a multi-mediator system. And leukotrienes represent another important pathway that can sustain inflammation. And if mast cells are truly driving symptoms in IBS, then it stands to reason that we should not only focus on blocking those downstream mediators, but also quieting mast cells themselves. Ketotifen is interesting because it works in two ways. It acts as an H1 antihistamine and also stabilizes mast cells and also blocks prostaglandins too, preventing them from preventing the mast cells, from degranulating in the first place. So instead of just blocking one mediator like histamine, you're reducing the release of multiple mediators simultaneously: histamine, tryptase, cytokines, all of the signals we've been talking about. And we have randomized control trial data to support this as well. In one study of IBS-D patients, those with diarrhea, treated for 8 weeks of ketotifen, about 76% of those had significant improvement in gastrointestinal symptoms compared with 38% on placebo. There was also objective improvement in visceral hypersensitivity as patients could tolerate more distension before experiencing pain or urgency. And what was cool is that when they looked at the tissue, they found that mast cell numbers decreased in the ileum and mast cell activation, meaning degranulation, was reduced across multiple regions of the gut. In the world of mast cell stabilizers, cromolyn represents a different strategy by inhibiting a process called calcium-dependent degranulation, one key step in mast cell release of their contents. And again, we have both controlled and real-world data to support this. In a randomized crossover trial of patients with IBS and foods intolerances, cromolyn led to significant symptom improvement compared to placebo. And then in a more recent real-world cohort looking at patients with IBS, functional dyspepsia, and gastroparesis, about 63% of patients had meaningful improvement with cromolyn. The final point here is that mast cell activation in IBS is not a one-size-fits-all process, and the same is really true for treatment. What we see clinically is considerable heterogeneity, not only in patient presentation, but also response to therapy. Some patients are histamine-driven, some are more leukotriene-driven, and others have a more systemic or immune-mediated picture. Because that treatment really needs to be individualized. There are supportive approaches like polyphenols, vitamin C, and L-theanine that can help stabilize mast cells. There are immune modulating therapies like omalizumab or Xolair, Plaquenil, tacrolimus, or JAK inhibitors that are reserved for more immune-driven cases. And then there are more neuromodulatory agents like low-dose naltrexone or even benzodiazepines in select situations, which can help regulate neuroimmune signaling. So the key takeaway is this: there is no single mast cell treatment or IBS treatment. Instead, therapy is layered and tailored based on patient symptoms, their triggers, and what part of their system seems to be firing the most. One final and important piece is the emerging role of GIP and GLP-1 agonists in treating mast cell activation syndrome in IBS. Well, I find this is purely anecdotal. I find them to be very well tolerated at low microdoses and more effective than a lot of the mast cell stabilizers that we've been talking about. One possible explanation is that they don't just act on mast cells directly, but work upstream by improving intestinal barrier function and tightening the tight junctions, thereby reducing the signals that activate mast cells in the first place. Traditionally, we think of GLP-1 as a metabolic hormone involved in glucose regulation and appetite, but newer data suggests that enteroendocrine L cells, which are these cells within our intestines that secrete hormones, are doing something much more sophisticated. They're not just sensing nutrients, they're also sensing barrier disruption and inflammation. And in both animal models and humans, when the gut is exposed to inflammatory signals, GLP levels rise rapidly. Specifically, when the gut barrier is disrupted, like in colitis, where there is inflammation there, or ischemia, where there's low blood flow, danger signals that are normally contained are now reach these L cells, and that triggers GLP release very early, sometimes even before traditional markers of injury increase. But GLP release doesn't just correlate with injury, it appears to activate repair pathways. In preclinical models, GLP-1 peptides increase expression of key repair genes within the intestinal lining. It also seems to directly strengthen the gut barrier and reduce intestinal permeability or leakiness after injury. And importantly, it also reshapes the immune environment, suppressing pro-inflammatory pathways and reducing overall inflammation. So when you step back, GLP peptides start to look less like a purely metabolic hormone and more like a part of a coordinated barrier response pathway. And so when the gut lining is stretched or breached, GLP-1 may serve not only as an early signal that detects injury, but helps initiate the process of restoring integrity and reestablishing balance. And I'm starting to believe that a small dose of GLP for many patients with IBS or MCAS with a prominent GI symptom profile can be beneficial, of course, taken on a case-by-case basis. So beyond a GLP medication, I continue to think more and more about barrier support for a lot of patients, and I will use these on a case-by-case basis. One example is prebiotic fibers, such as inulin. These prebiotic fibers are not digested directly, but are instead fermented by gut bacteria into short-chain fatty acids, namely something called butyrate, which serve as fuel for epithelial cells. This improves tight junctions and helps shifts the immune system towards a more regulated anti-inflammatory state. Similarly, human milk oligosaccharides, or HMOs, have been shown to reshape the microbiome, increase bifidobacteria, and increase SCFA production. And then on the amino acid side, glutamine or glutamate play a more direct role in tight junction repair. And in inflammatory models, glutamate has been shown to increase tight junction proteins and at the same time suppress inflammatory pathways. Then there's this other pathway, vagal nerve stimulation, which is fascinating, and there's emerging data about this, which can help calm inflammation and reduce inflammatory signals in the gut by supporting the cells that hold the gut lining together through something called the cholinergic anti-inflammatory pathway, which goes through the spleen and supports these cells called glial cells, which helps reinforce tight junctions in the bowel. And in doing so, it may help strengthen the barrier and make the gut less sensitive over time. And the key here is that instead of chasing downstream symptoms, we can support the system at a level where this whole process begins, or maybe at the gut barrier itself. So we step back and put all of this together. The way to think about IBS is not a disorder of nothing, but a disorder of amplified signaling across a neuroimmune barrier network. The symptoms are real, measurable, reproducible. They just don't show up on the standard scope or CT scan. At the center of this, we see three players interacting: the nervous system, the immune system, particularly mast cells, and the gut barrier. Stress doesn't just stay in the brain, it is translated through CRF into immune signaling. Mast cells sit right at that interface, and in IBS, they appear to be more numerous, more active, and more closely connected to nerves. And that creates a system where normal stimuli like food, intestinal distension, or even subtle environmental triggers can be perceived as pain. And importantly, this is not simply more stress. Stop it with this. It's an exaggerated response to stress. And the question becomes, what has made this system more sensitive? And what we see is that barrier dysfunction, environmental exposures, and prior inflammation may play a role in priming this system. And that leads us to treatment. There's no one single answer, but we can intervene at multiple levels, calming mast cells, blocking their mediators, regulating neuroimmune signaling, and importantly, supporting the gut barrier itself. IBS is not a mystery, it's a systems problem. And once we understand the system, we have many, many ways to help these patients. Thank you for listening. Enjoy the rest of the conference, and please send any feedback or questions my way.